have a patient with an infrarenal aneurysm, and next slide, please. It's a 75-year-old patient with coronary artery disease, COPD, diabetes, and renal insufficiency. Next slide, please. The patient has an asymptomatic infrarenal aneurysm with a maximum diameter of 55 millimeters. The proximal neck is slightly bell-shaped. The patient has a prominent inferior mesenteric artery and calcified iliac arteries. The next slide, please. So we see here the slightly bell-shaped proximal neck and the aneurysm. The next slide. What we did see is that the patient has an IMA of about 5 millimeters. So we did decide to treat this patient with preventive IMA plugging. So this is the projection of the inferior mesenteric artery. We can see, this is where we can see the orifice of the IMA.
Very nice.
Yes. We have selectively catheterized. We have used a steerable sheath to go into the vessel. We had some problems advancing our Bernstein catheter due to this orifice stenosis. And it was good that we had the steerable sheath to give us some more stability. And this was the selective angiography of the IMA. So we see that it's quite prominent. We prefer to do preventive plug embolization in these cases. We have also published two papers in the last couple of years with good results with preventive plug embolization. So this is a point where we push our 6 millimeter plug inside the vessel, then retract our catheter and deploy the plug. So we, of course, do not expect that it is fully occluded, but it will occlude with time. And we then proceeded to deploy our main graft. We have been using a C3 device for this patient. So retraction of the sheath, deployment of the proximal part of the main body, and then we proceeded to catheterize the contralateral limb. We already had the steerable sheath in the left iliac artery, stiff wire, a control angio before complete full deployment of the proximal part of the stent graft. We balloon the proximal part of the stent graft and the left iliac limb. And at this point, we have advanced our aptus endo-anchor system to do fixation with 6 endo-anchors. We see that we have a perpendicular axis to the proximal end of the stent graft, pushing the endo-anchors against the graft, and then fully deploying the first one.
Is there any specific reason why you use these endo-anchors in this case?
Well, we had a slightly conical shape, a slightly bell-shaped proximal neck with about 15 to 20% diameter increase from the proximal end right before the aneurysm begins. That's why we decided to fixate it additionally with the endo-anchors.
It's Roger Greenhouse speaking. Do you have fixed criteria for the use of endo-anchors in a primary situation? And do you also use them in the secondary situation if there's a problem?
Yes, we do use them in a secondary situation if we have type 1 endoleak or distal migration of the graft. Of course, there has to be a position of the graft to the aortic wall. If there is a proximal aneurysmal disease to the graft, then we prefer to extend proximally with a fenestrated graft. For the infrarenal, for the primary use, we do feel that when we do have a conical, bell-shaped neck, we can use them, but anything below 10 to 8 millimeters is, in our opinion, rather an indication for a fenestrated device rather than for the use of endo-anchors. We are now going to deploy our final step. We're just going to deploy the right limb. This seems to be a good position. We're going to do an angiography over our sheath in the right side after pulling back. Okay, this is a good position. Okay.